Good afternoon, everyone. Welcome to Live Studio again. It's still continue running, exploring the most exciting fields of endodontics. And now I have a pleasure to interview these three gentlemen about mechanical root canal instrumentation. So let me present my guests. We start with Gianluca Plotino, who is an endodontist working in Rome in his private practice. And he's been doing extensive research within the field. We have Marco Varsiani coming from Brazil. He got his education at University of São Paulo, working now at the military hospital. And we have Emmanuel Silva, who is working as associate professor at the University of Rio de Janeiro and doing research in the field. So let's start by grounding the discussion. In your opinion, and this is the question for everyone, what are the truly evidence-based fundamentals of mechanical instrumentation that every clinician should possess, regardless of the system they use?
First of all, thank you so much for the invitation to participate to this really nice event and really nice format that has been launched in this congress. So thanks for everything you are doing as a committee or communication committee for the ESE. This is an hard question to reply because when we speak about evidence-based dentistry and endodontics in particular, it's very difficult to find some clear response because we have not so much clinical evidence about this. And for what concerns the root canal instrumentation, it's the same. It's very difficult to run studies to establish a clear clinical evidence, just selecting this parameter as the primary outcome of our studies. So this is something that is always a call for action for researchers, for university, because evidence-based it's difficult to be followed. So today it's probably mainly related to something more clinically evident, that is us as a leaders, opinion leaders, trying to guide the dentists and endodontists through these technologies and these techniques.
Yes. Do you have any input on that, Marco?
Yeah, actually, I would like first to congratulate you for this initiative because it is important for other people to have contact with us in another way, not only on this stage, right? Well, when we talk about scientific evidence in a biological field, we need clinical studies. And in this way, clinical studies in endodontics were still very poor in this aspect. So we do not have so strong scientific evidence of anything. This is why everybody says that every path leads to the Rome, which means that we have different ways to reach the same goal. And in this way, unfortunately, we do not have a specific point that I can tell you. This is completely proved by science and by clinical studies. But we need to manage this with some laboratory studies and some other in vivo studies that give us a glimpse of what we can do to improve our treatment. And I believe in the next question we will be able to do it. So
Emmanuel?
Amazing. Well, congratulate you for the organization of this special thing. And after those two guys, I have nothing to add. And I think we will have more discussions in the other questions. So let's move further.
So I have a new question for you, Emmanuel. A significant amount has been published recently on shaping strategies, file design, and movement kinematics. From your research perspective, which innovation have genuinely improved biological and mechanical outcomes? And which do you feel are making marketing than a substance?
Okay. Well, I think biological and mechanical are interconnected. So uh, we should answer both questions together. And I strongly believe that thermal treatments and mainly the modifications in kinematics could enhance mechanical preparation, making it easier, making it safer. So I think those two strategies were really interesting for endodontics. What was the second question?
if there is something that is more like a marketing than really
A
a
lot of
substance.
things.
Yeah.
Impossible
The
to
rest of it.
choose one, just one. Yeah.
Okay, thank you. Gianluca, in terms of minimal invasive endodontics, often appears connection with modern file systems. From your experience with micro CT and structural analysis, how do you define the line between conservation and compromise?
It's a really interesting question because it's always difficult to establish these borderlines. I like to mention the ancient Romans people that use it to say in medio stat virtus. So the truth often stays in the middle between extremes. I don't like extremizations at all. So what I like to say is that we are going towards this trend of minimally invasive dentistry in general, and endodontics is following this trend thanks to the evolution in techniques, evolution in materials that permits us to be more conservative. One of my mentors told me that dental structure is owned by the patient, so you cannot steal this dental structure. You must do as much as you can to maintain the dental structure as possible. And now, with the modern technologies, modern instruments, modern materials, we are able to maintain as much to structure as possible. That means that we have to balance in between the biomechanics and the biology, in between the mechanical needs to maintain as much to structure as possible, hoping to increase the resistance of the tooth over time, and so the possibility that the teeth can be maintained for entire life of the patients. But we are also a specialty that we have to deal with the biology, with the microbiology, the infection. That is, bacteria are our main enemies. So we have to do as much as we can to solve the bacterial problems, solve the pathology that we are dealing with. So we have to find always a balance in between the debridement, disinfection, biological aspects of our endodontic professions and the new biomechanical needs to retain teeth for the entire life of the patients.
Thank you. Now, question to you, Emmanuel. Your research has shed light on the limitation of traditional metrics for evaluating instrumentation outcomes. Could you highlight the most misleading clinical assumptions that persist because of outdated evaluation tools?
Difficult question, but I will, for example, try to explain how some people try to translate the cyclic fatigue to clinics, and this is a problem to me because some people believe that the value that you have in a cyclic fatigue test is it signifies that you can use this instrument in a clinical setup for the same second that it resists in the cyclic fatigue test, and that's not true. So I think this is one of the examples that we have of misleading the translation from lab tests to clinical setup.
And Gianluca, you extensively studied shaping efficiency, canal cleanliness, and fatigue resistance. How should clinician balance consideration of file safety, shaping ability, and cleaning effectiveness in complex cases? What would you advise on that?
Yeah, I strongly believe that endodontists and clinicians should train themselves in terms of knowledge of the basic principle of endodontics and the basic knowledge about the instruments and materials that they are using. So they must have a deeper knowledge about what they are using clinically, because this will create a background for anyone to reason with their minds and their brain to choose which is the best instrument for them and for their clinical needs and for their patients. So my suggestion is to really try to study the different properties of the instruments, the different characteristics, design, and how these properties may impact their instrumentation of the root canal. So the cutting efficiency of a file, how it may help the file to advance inside the root canal by reducing the tendency of the tip of the file to be blocked inside the root canal. So by reducing the taper lock and the deformation and fracture, how to how which is the flexibility of the files and the balance in between torsional resistance and flexibility to be used inside the root canal. So they must know the metallurgy and know the different characteristics of the different metal treatments so that they can use an instrument that is a little bit more rigid for a specific canal, for example, more calcified, or a more martensitic, more flexible instrument, for example, for highly curved canals. So my belief is that they must have in their mind, in their brain, the background knowledge to choose the best for any single clinical situation.
I agree on that. And Marco, your microcity research and anatomical analysis emphasize how canal is complex, root canal is complex, with curvatures, isthmuses, and so on. How can clinicians practically calibrate their instrumentation strategy in real time in the clinic to handle such complexity?
Okay. Uh, to calibrate the instruments in real time, it depends on a lot of knowledge because nowadays most of our education are being made by opinion leaders from companies or from the companies itself. So most of what clinicians learn today are coming from these guys. And these guys are trying to give a simplistic way that the clinicians should use some systems in the way that they can reach their objective. So to be able to decide what to do during a root canal treatment, the clinician must be independent of this kind of education. Of course, they started from that, and from that they must evolve. Uh, but there are some points that we can talk about. For example, you told about different types of complexities.
Yes.
In a curved canal, of course, you need a flexible instrument. So you need to look for a flexible instrument to do that. At the same time, you need an instrument that is strong in terms of torsional strength and cyclic fatigue resistance. So this is a type of knowledge that you must have to choose what instrument to be used. In a canal with anismus, for example, anismus we know we are unable
Yes.
to instrument anismus. So you need to focus your preparation not in the instrument, but in your irrigation procedure. And that's how you think, how you plan how to do with different cases of complexities.
So we can say we have a red line here. It's like knowledge and logical thinking, to make a good root canal
Exactly.
treatment.
Because you asked me about in real time what to do. If the guy is prepared just to use the sequence that the manufacturer told him to do, this is complicated.
Yes, that's true.
We have a big responsibility as teachers
Yes.
to give the correct messages to the colleagues.
Yes, and unfortunately, as you said, many of young dentists they look at Facebook University, and look for knowledge there because it's very easy to look up, and you don't have to have so much effort. Well, Emmanuel, if you had to choose one aspect of mechanical instrumentation in clinical endodontics that is consistently misunderstood or misused, what would that be?
Always difficult questions. Well, maybe flexibility, because people flexibility is important, of course, but we do not need the most flexible instrument that we can have. As Gianluca brilliantly said, we need a balance between flexibility and resistance. Because when you have a too flexible instrument, your instrument usually has reduced torsional resistance, and it's more prone to fracture due to torsion. And also, the instrument with a really great flexibility probably will not be cutting really well. So you have to add some strategies to the instrument, such as improving the rotation that the instruments are used inside the root canal, or improve the torque in the motor. And this might lead to fractures or some major problems. So I think we need to understand better the mechanical properties, for example, flexibility, torsional resistance, and to understand how these properties will relate to the clinical setup.
Yes, thank you. And Marco, talking about these micro CT scans that you are doing a research on and taking into consideration the anatomical variation in the tooth, which sign in which anatomical warning sign would you say is most important to warn the dentist before the root canal treatment preparation? The pitfall of anatomy.
Yeah. Can you repeat the question?
Yes.
So,
Yeah, what would you say that it's a pitfall of anatomical variation in the tooth when it comes to root canal preparation?
okay. So, uh, actually, you are doing hard questions because almost all of them we do not have a definitive answer,
Yeah.
right? And in this way, what I can
Was the
tell you,
intention? That was the intention. The
no, no,
difficult.
yeah, actually, the knowledge of the most common anatomic variations is the principle that all the clinician needs to start with, and after that, he need to learn what the differences or the variations that they should find in some groups of teeth, and based on that, this is the point where he he will start to think of how to choose the best mechanical system, or if he's going to uh, be more cautious regarding the irrigation protocols. So this balance is not so easy to do, but what I can tell you is this: first, we need to know about the most common anatomical variations, and from that, you need to decide what to do.
Thank you. So now I have a question to everyone. We'll see who is answered the first. For clinicians with busy practices, how should they objectively evaluate new instrumentation system, moving beyond marketing claims before adapting them?
To start?
It's difficult to answer this question if you have a busy practice, because my honest reply would be you have to train yourself as much as you can. For example, by using and trying new instruments, comparing new instruments in extracted teeth. This is what I have done in my training period when I was younger. I have done a lot of research, and during my research, I have treated thousands of extracted teeth, and this helped me so much to understand the properties of the different files, but also to have knowledge about the anatomy, the anatomical complications, the real complications in real teeth that then I found back in the mouth of my patients. So training is very important, not only participating to training courses, workshop, congresses like this that upgrade your skills, but also working in your own office on extracted teeth to practice yourself and try to understand the different types of instruments, materials that you are using. And today, if I can add something to what Marco said before, the possibility to 3D print anatomical variations with the new technologies that we have helps also us and clinicians to train themselves in real clinical situation that comes from their great studies on micro CT. We can print this variation and try to treat them in the office before to go on the patients. We can also print the specific tooth of a patient that we are going to treat in the next week and try ourselves on that model. So this is a great advantage given us by the technology.
Do you want to add something, Marco? Please.
I would like to add something, maybe just to organize a little bit what Gianluca said. I used to say that in our practice today, we have 3 points that we need to base our practice. The first one is knowledge, which is the basic one. The second one is what he said, it's training, right? And the third one is technology. So this is the three basic points that we need to follow to have a good practice in our offices.
And what I think is very important, what you said, Gianluca, that the plastic models are amazing nowadays, but the feeling of doing root canal treatment on the extracted tooth is it's the best.
Yeah.
That's why we should do it. We should evaluate these instruments on the extracted teeth.
Yeah, I totally agree with Gianluca. I think training is the first point and the most important point to evaluate an instrument. But we should also look for independent research and try to understand what research are stating and what variables are being evaluated so we can translate this to clinic. But training is the most important when you want to try and use and incorporate into your clinical scenario a new endodontic instrument or a new endodontic system.
I would like to add something to your question regarding the artificial or printed teeth.
Yes.
Yes. Actually, to print the teeth, the technician needs to increase the size of the root canal because the current printer, they do not have the resolution enough to print all the details of the canal anatomy. In this way, when you're working in a printed teeth, you are not working in a real dimension, in a real canal with the real dimension, but a dimension a little bit
Bigger, yeah.
bigger. And the other problem is that the resin is softer than than the dentin, and is softer than the resin blocks that we used before. And this is the reason why most of the times you do not have fracture instruments in hands-on, because this printed teeth does not allow you to fracture an instrument.
Yeah. So extracted teeth, that's the first choice, of course. Yes. Okay. Emmanuel, you proposed a new approach in vitro testing of instrument. How does this differ from previous methodologies? And which earlier tests, like fatigue test, torsional resistance, and flexibility, are clinically irrelevant in your view?
Okay. First of all, it was not only me. It's our group, a huge group, and we have to thank them for the possibility to do the multi-method research. I think the major point, the main point in the multi-method research is that we can triangulate the results. So we can explain how, for example, mechanical tests why the results of mechanical tests was that based on geometric design or metallurgy of the instrument, and I think this makes the difference in trying to explain the results. And the second question, which was
No, you
no
answered
question.
it
Okay,
perfectly.
so
Yeah.
that is.
Yeah.
I don't know if Marco has something to add because
So, question to Gianluca now. Can you tell us what's the current evidence based supporting minimal invasive endodontics? Clinical clinicians always share their cases on Instagram, with shape to sizes like 1703 or Nimia preparation. So, is it acceptable? And what criteria do you think there are?
You said well. Up to date, the evidence that we have is clinical cases that we are all doing day by day by trying to maintain this principle that I was describing before, in a balance in between mechanical properties and biology. So we all have a lot of clinical cases done day by day. We are following them up over the years, hoping to have better results rather than before. But this will be only demonstrated by serious clinical studies, randomized clinical trials that can be only done by serious research groups that we have like them and published in the most serious endodontic journal like the International Endodontic Journal. So today we have not that much evidence, but I think the technology that we are going to have will permit us to limit the mechanical instrumentation to a certain small size, as we probably will have device that will make us be able to clean that spaces even in a small sizes, and we will have new materials that will help us to fill these root canals that has not been prepared, because this is another important topic to speak about. Minimally instrumented canals are very difficult to fill up in the obturation phase. So we have to find a strategy also for this third part of the endodontic triad.
Could the use of laser justify such minimally invasive approaches, given the limited evidence regarding their effectiveness in small canals?
It's not only about lasers, but I will speak about this type of technologies in general that may help us to reduce the number of instruments used and the size of the instrumentation. I think that we will finally reach the point in which a technology like this one may help us to reach this aim and this point.
Thank you. Marco, considering your anatomical research, should clinicians routinely take CBCT scan before the treatment to decide for instrumentation strategy?
Oh, yeah. This is a tricky question, but actually, each country has its own regulations about CBCT. So, if you are in a country there is a regulation about this CBCT, follow it. But in general, what I can tell you is that there are some cases that CBCT really makes difference, and sometimes in retreatment cases or cases in which you see that maybe something is different about the anatomy when using a common radiography. So this is the basic indications that I think that CBCT should be used. In retreatment cases, I think it's the norm. You need to use it. And the second one is when you see that something it's different in the radiography, and you need to check the anatomy for that. This is my opinion about this subject.
I agree totally. So finally, Marco, is physically touching all root canals wall truly ideal? Shouldn't the focus shift to touching fewer canal walls to minimize the creation of smear layer and debris?
Yeah. If touch the root canals was something that we should do, all root canals were given wrong all during all this time because we were never able to touch all the root canal walls. So touch all the root canal walls is not a goal. We don't need to think about this. Of course, that as much root canal walls you touch, it would be better, mostly in necrotic case. In vital cases, there is not so much importance. And regarding the second part of your question, actually, there is a misunderstood about the importance of tissue debris and smear layer. Our problem in endodontics is not tissue debris, it's not a debris or a smear layer. It's called bacteria. So it's against it. If the debris is contaminated, okay. But our problem is the bacteria. So our focus should be done in develop something that could help us to neutralize or to remove bacteria. And if this effort would remove a smear layer and the hard tissue together, good. But our focus should be otherwise. So there's a misunderstood. We do not need to think about hard tissue and smear layer as a problem. Okay? That's my the way I think about this subject.
Thank you very much. Well, let's hope, everyone, that soon there will not be any problem with bacteria killing within endodontics. And I thank you so much, gentlemen, for this nice discussion. We appreciate you coming to our studio. And you who are watching, please stay tuned. We're going to be still sending the whole day today and tomorrow. Thank you. Thank you.